session, we will explore how AI and human expertise can be structured within clinical workflows. This session is hybrid, so we'll be having 2 speakers joining us live and 3 speakers who have pre-recorded their speeches. So we're joined by 5 distinguished speakers for this session. We have Dr. Lawrence Marks, Assistant Dean of the School of Medicine at the University of North Carolina at Chapel Hill. We have Dr. Lukasz Mazur, Professor and Director of the Division of Healthcare Engineering at the University of North Carolina. Dr. Todd Pawlicki, Professor and Vice Chair of Medical Physics at the Department of Radiation Medicine and Applied Sciences at UC San Diego. We have Dr. Brian Anderson, Assistant Professor in the Department of Radiation Medicine and Applied Sciences at UC San Diego. And finally, we have Mr. Aditya Naskar, Director of Monitoring, Learning and Evaluation at IntelliHealth. With that, let's begin our first presentation. It's my pleasure to invite Dr. Mazur to kickstart the first set of presentations. Dr. Mazur, over to you.
Thank you. Thank you so much. Just making sure you guys hear me okay?
Yes, we can hear you.
Thank you. Perfect. Well, thank you. It's really a honor to be able to present and be part of this part of the program. So thank you so much for the invitation, and hopefully we can provide you with some interesting material that we can further discuss. Just as said, this presentation is a joint effort between UNC and the University of California, San Diego, as we try to kind of bring the experts in the field of patient safety and radiation oncology for you. My disclosures, just really quickly, none of them are really in any effect in this talk. So those are just for you to know. Before I start, I really want to give a little bit of a credit to a lot of people that work with us to be able to generate the knowledge, the research, and for us to share. So as you've heard, on the top row, you have the speakers for today, Dr. Marks, Dr. Pawlicki, Dr. Anderson, myself. But our team that investigates application of AI in a trusted way, in a safe way, really includes a lot of other people, as well as our PhD students. And I really want to just pause for a second and really say that Dr. Kartika Thapa, while being with us at UNC for a number of years, really contributed in a great sense to the vision of this work. So again, just big thanks to a lot of people that contribute, and also a lot of the work and the results that I'm going to be presenting have been funded by by ARC, our one of the national institutes that provides funding in our country for patient safety. Okay, so the agenda. What we have for you is I'm going to give a little bit of a background information in a second, and then we're going to have recorded talks by Dr. Marks, who's going to really give you a little bit of a background about the importance of peer review in radiation oncology. And again, the goal for introducing this is thinking about how we're going to introduce AI systems into peer review where cases of radiation oncology are being reviewed in a multidisciplinary group. So we want Dr. Marks to give you background, importance, and really set the stage for this idea of peer review in our in our radiation oncology. Then we're going to have Dr. Pawlicki coming in with a little bigger picture and really thinking about system as a whole and what are the opportunities and some challenges within radiation oncology to implement artificial intelligence. And then I'm going to kind of come back and try to give a good application of one of the AI research programs that we have, explain what is the AI model, and really start talking about this idea about how much do we need to think about this division of labor, how much AI should do, how much people should do, and how do we partner together for the best benefit of patient safety. So we're going to talk through this, and Dr. Anderson will explain a little more technically in the video about how we developed and tested our AI model. So that's the agenda. That's what we're going to try to get through in the next about 15 minutes. Okay, So background, what you see on the slides, on the top right corner, you see my kids. That's Alexander with the soccer ball and Sebastian with the football, American football ball. On the left, you see a picture of a plane and a picture of our campus in Chapel Hill. And what I want to say is that when I think about putting my kids on a plane versus putting my kids into the hospital, I'm still more nervous about practicing and researching the healthcare industry. I'm more, scared putting my kids in a hospital than putting them on a plane, and I don't think that is acceptable. We have tremendous opportunities to do better, to really think about patient safety. And my inspiration for the work, for many years I've been practicing, really comes from the engineering background, from human factors. And there's a picture at the bottom right corner of Professor James Reason that really taught us a lot of lessons about how systems interact. He's very famous for what we will call switch cheese model, and really kind of inspired us to kind of think about the system and how to design systems to prevent harm and moving forward. So let's talk a little bit about radiation oncology. It's a very complex, relatively very complex system. It starts with the consultation, then it goes into imaging, and with the symmetry, there's a lot of planning, interaction with physicians of how to optimize a plan of providing radiation to the patient. That plan, after review, including the peer review of colleagues, then goes to physics, where there's a lot of quality assurance to ensure that the plan can be delivered by the machine to the patient, and then the patients come for treatment. And in a sense, if we think about radiation oncology, for decades, it has been heavily relying on technology. And as we bring AI to our system, perhaps radiation oncology is one of the bellwethers. It's a great application area to see if we can do a really good job already in the industry and in an area where technology is so prominent, and do a good job of bringing AI and gaining the efficiencies, gaining patient safety, and at the same time ensuring that the people that deliver care, they can do this in a happy, joyful way, without burnout and without kind of these unnecessary, unintended consequences. So we're talking about radiation oncology and the process and how we can really do this. So what I want to kind of start here is go back to James Reason and really help us think about this division of labor. Because at the daily job, when we have this magical radiation, curing people on a daily basis, every 15 minutes, a patient comes to a machine with multiple machines and receiving radiation and hopefully curing cancer, right, at this moment, curing people to have a better life. A lot of human errors, as described in our current data, what we have, will be pointed to the action of a human error, which is incorrect. The way we've been thinking about for decades about describing our mistakes and errors and what happens in the systems, unfortunately, points to a human, right? Points to that at the end of the day, there was someone who did something wrong and harm occurred. That is the database that we live with. But really, what we need to start thinking when we bring the AI models into healthcare, we need to start expanding our understanding and really thinking about the interactions. And one of the layers that we need to start looking is the usability, right? There's a lot of human factors that comes with the usability of how to make sure that people can use the new AI models, the new interactions in a usable and human factors friendly way. The next layer, we need to think about all the workflows and all the communications. We can also think about it that there's a lot of teamwork that occurs. And and as we design AIs and as we think about it, we need to really kind of take care of these interactions between, right, how people work, how they view all the interactions and all the usabilities, and go into, doing their teamwork, talking to each other. Finally, I do want to point out that, of course, all of the organizations live in the layer that exists policies and procedures. And we cannot forget that those policies and procedures need to be updated. We need to think differently about how organizations function in this new era that is coming with artificial intelligence. So the last point I want to make is that in the mindset of patient safety, it is critical for us to start identifying threats, thinking about what are the exact threats and listing them, just like high reliability organizations done for many, many years, and understanding each threat and understanding how we design and write our policies, new teamwork, how we have the usability, so we prevent, right? We want to prevent the human doing kind of the wrong thing. So there's a lot of opportunities. I'm extremely excited about the opportunities that exist right now with bringing artificial intelligence and the amount of work that we can do to ensure patient safety. So with this in mind, I do want to, kind of point to one of the papers that we wrote that I think kind of lets us really bring some important knowledge from human factors, especially from barriers management, and how high reliability really organizations are really teaching us that how to design proper barrier to prevent these threats from happening in our organizations, right? So there's a lot of potential learnings and opportunities that we have of this type of a thinking, application of this thinking in our new systems. I'm going to turn to Dr. Marks for the next presentation. That, as I said, and Dr. Marks will really set the stage about the peer review. So I'm going to play the talk by Dr. Lawrence Marks.
Hello, my name is Larry Marks. I'm with the group from UNC, and we are very thrilled to be here. Thank you so much for the invitation to be part of this program. I'm going to talk today about peer review in radiation therapy, the role of peer review and the associated challenges of peer review. I'll be kicking off the group today with introductory comments, and my colleagues will follow. To conflicts of interest. This is where we are from, Chapel Hill, North Carolina, on the east coast of the U.S. This is what I hope to cover in my introductory comments here. Radiation oncology, very technology-driven, but we are human beings operating this. There's a critical role of how we actually literally draw on medical images, and there's a lot of variation in that, and that's where peer review becomes important, and this is where AI may be helpful for us. So radiation therapy, this is a critical component of anti-cancer therapy, both in the curative and palliative settings, also some benign diseases. And there's a lot of technology, but it's fundamentally a human endeavor. So many of the decisions are based on physicians and physicists and dosimetrists and therapists making decisions for each individual patient. And here is a good example of this. When we treat a cancer, we have on imaging the tumor we could see. That's what we show in the dotted line here. That's the gross disease that we see on the medical imaging. However, when we decide what we want to treat, we recognize that we need to treat also the microscopic extensions that extend from that gross tumor. And also there could be some other sites of microscopic cancer that are in other sites, such as in lymph nodes, that the cancer may be predisposed to spread to. So this is what this might look like in this cartoon. We have this blue patient lying down, going into this donut, which is a CT scanner. The CT will take images of the patient at different levels. This is essentially dividing the patient up, slicing them like slices of bread. And we then look at the CAT scan images as each one of those slices of bread. This is what it might look like. This is an axial CT image. So it's a CT image taken through the pelvis of somebody with prostate cancer. And the images don't have these colored lines on them that are shown. These colored lines are drawn onto a computer screen by human beings. Humans will take the time and draw all these things out. And it's based on that anatomy that we plan our treatment. So these are the various things that we draw up. And I label them here for you. The way this image is oriented, the front is here as labeled, the right and left as labeled. I draw your attention to the blue contours, which are these lymph node areas. We don't see any cancer there, but we know from experience that the prostate cancer, in this example, can spread to those lymph nodes. So when we make a radiation plan for a patient, we might generate something like this, where we deliver a high dose to the red polygon at the bottom and a medium dose to the blue polygon to cover those lymph nodes. So this is all fine. We do this all the time. The challenge is there's a lot of variation between physicians. We don't have strict guidelines of exactly where these lines need to be drawn. For some areas we have it, for some areas we don't, but there's a lot of variation here. And this is the human part of medicine. This is the reality of how radiation is practiced. And the way that we often go about sort of correcting for this or adjusting for this or being sure that everybody's getting good care, we often use peer review. So this is where one physician may be planning a case, but before they finalize that case, it gets reviewed by their peers. Other physicians will look at this. Physicists, dosimetrists, other physicians who are used to looking at these images will look at them and give feedback to the physicians. This is one of our, there's a room where we actually do peer review at UNC, and this is the usual conversation that may take place between people in this room. And the peer review is, again, helpful in this setting because peer review can address some of the inter-doctor variations. But peer review has a lot of challenges. There's a lot of images to look at. I showed you one image there, but a typical patient with prostate cancer that we're treating may have 20 images like that to look at. So you have the physician who's doing all this drawing, and then you're asking a group of other physicians and physicists and dosimetrists and other professionals to review that and provide feedback. It's a lot to look at. It takes time and a lot of things to consider. And it's very hard for doctors in small centers with there are very few physicians around to provide peer review. It's very hard for them to do peer review. And also remote peer review is challenging also because you're not in the room with people. There's some reluctance sometimes of criticizing a colleague. There's a lot of things that make peer review challenging. So we are hopeful that AI can perhaps facilitate peer review. And my colleagues are now going to speak more about some of the details of the initiative that we have at UNC and the concepts that we're trying to promote in the realm of using AI as a means of improving peer review, as a means to improve, as a way of improving the overall quality of radiation treatment. Thank you so much. Again, it's a pleasure being here. We so much thank the organizers for inviting our team to be with you at this meeting. Thank you so much.
Well, thank you. I'm going to now transition to the talk of Dr. Pawlicki from University of California. And Todd is going to talk a little bit bigger picture about application of AI in radiation oncology.
Hello, I'm Todd Pawlicki, Professor and Vice Chair of Medical Physics at the University of California, San Diego. Today I want to talk to you about artificial intelligence in radiation oncology quality assurance, not just as a standalone technology, but as part of a broader evolution in how we think about quality and safety in complex clinical systems like radiotherapy. These are my disclosures. I will not be talking about any of these in this presentation. Radiation therapy has never been a static field. From the earliest days of simple treatment setups and hand calculations to online adaptive workflows, our technology has continually evolved. With each step forward, we've gained precision, accuracy, and capability, but also increased complexity. Artificial intelligence is simply the latest chapter in that story. It represents another major shift in how work gets done, how decisions are supported, and how quality assurance needs to be approached. And that's why we're talking about AI today. Before going further, I want to say a quick word about terminology. I'm going to use the terms quality and safety somewhat interchangeably. Safety is fundamentally about preventing harm, making sure that the care we deliver does not injure the patient. Quality, on the other hand, is about excellence, delivering care that is effective, efficient, timely, and safe. In practice, these two ideas are intertwined. You cannot have safety without quality, and quality without safety is meaningless. So for the purposes of this talk, when I refer to quality or safety, I'm really talking about both. We're talking about artificial intelligence now for a very few practical reasons. First, there's simply far more data available to us than ever before. Data coming from our patients and patient treatments, as well as from our equipment. Much of that data contains signals about quality and safety, but only if it can be analyzed effectively. At the same time, radiotherapy continues to increase in complexity. Our workflows involve more steps, more software, and more interdependencies than in the past. As systems become more complex, it becomes harder to reliably see where risk is accumulating. Layered on top of that are the limits of human abilities. We all bring cognitive biases, finite attention, and variability in judgment. Even highly experienced clinicians can struggle to detect subtle patterns or early warning signs in large, complex data streams. Taken together, these factors make ensuring quality and safety increasingly challenging using traditional approaches alone. In that context, AI will be a part of radiotherapy QA in the future because it can provide new ways of seeing and addressing risk. To put AI in context, it helps to briefly step back and look at how quality assurance in radiotherapy has evolved. Early on, QA was largely expert-driven and local. Individual clinicians and physicists at each center developed their own ways of ensuring that equipment was functioning properly and that good clinical decisions were being made. Peer review played a central role, and safety relied heavily on professional judgment and experience. Then, professional societies began to formalize these efforts. Task group reports and guidance documents recommended QA tests, schedules, and tolerance limits for equipment performance. This brought consistency and standardization across centers. As technology advanced, semi-automated tools emerged to support these QA activities, making measurements more efficient and reproducible. And then, more recently, there's been a growing emphasis on incident learning, with incident learning systems developed to allow clinicians to capture, analyze, and learn from errors and near misses. Each of these steps represented progress, and each also reflected the tools and thinking of its time. Building on that history, the most recent recommendations around quality and safety represent an important shift in emphasis. Rather than focusing primarily on retrospective measurements and checks, the emphasis now includes prospective and risk-informed approaches to QA. The idea is to identify how processes and equipment can fail before harm occurs, and to design safeguards to address that. Critically, this also means looking beyond individual process steps or pieces of equipment and instead examining how interactions between components, people, and technology can create hazards or amplify risk. Quality and safety should no longer be viewed as isolated activities, but as integral components of an overarching quality management program. QA becomes something that is embedded across the entire care pathway rather than a set of disconnected tasks performed at the end. One important lesson from this history is that every advance in quality assurance solves some problems, but also creates new avenues for risk. Each new tool or approach tends to reduce certain types of hazards while simultaneously introducing new ones. Often, those new hazards don't come from the technology itself, but from changes in human behavior. How much we trust the tool, how much we rely on it, and how our work adapts around it. This pattern isn't unique to AI. We've seen it in earlier forms of automation with planning systems, LINAC operations, and record and verify systems. Recognizing this dynamic is essential if we want to adopt new approaches to QA without unintentionally creating new safety vulnerabilities. With that in mind, it's helpful to think about where AI fits in the ongoing evolution of radiation therapy, particularly as it relates to quality assurance. AI is not something that's waiting in the future. In many cases, it's already embedded in our routine clinical work. We see it in contouring and treatment planning for online adaptive treatments that are now used every day, and often used without explicitly labeling them as artificial intelligence. Looking ahead, it's very likely that AI will continue to expand in two important ways. First, as a set of tools that will directly support quality and safety, for example, by identifying patterns, anomalies, or elevated risks. And second, as functionality that is increasingly embedded within systems and software we rely on, shaping how work is done even when it isn't explicitly framed as QA. The key point is that AI is becoming part of the fabric of our clinical systems, and that is important. It has important implications for how we think about quality and safety. When we think about the opportunities for AI and quality assurance, several themes stand out. One of the most important is the ability to combine and make sense of data sets. AI can help integrate information from patients, equipment, workflows, and systems that are often siloed, allowing us to see patterns that would otherwise be missed. AI also offers opportunities for automation, standardization, and simplification. This can reduce unnecessary variability in how QA is performed and help ensure that best practices are applied more consistently. Perhaps most importantly, AI opens the door to predictive monitoring. Rather than waiting for tolerance limits to be crossed or incidents to occur, AI can help detect early signals of machine drift, workflow deviations, or emerging risk. And this will be accomplished with a minimum of additional work. Taken together, these capabilities point towards a shift from reactive QA to more anticipatory, risk-aware approaches. An important implication of this shift is recognizing that risk is contextual. Not all pass-fail decisions are equal, even when they meet the same tolerance criteria. Two situations can be both technically pass QA checks, but also have very different levels of underlying risk. To understand that difference, we need to look beyond individual test results and consider how elements of the system interact. Risk often emerges from the way people, processes, and technology come together, not from a single component failing in isolation. By understanding those interactions, we can begin to prioritize our quality and safety efforts more intelligently, focusing attention and resources where the potential for harm is greatest, rather than treating all situations as carrying the same level of risk. It is also important to recognize that quality assurance is a particularly high-risk application for artificial intelligence. One reason is that AI models are inherently opaque. We can't fully understand how models arrive at a given output. This makes validation and error detection more challenging. In addition, AI systems can produce variable outputs even under similar input conditions, which complicates their use in safety-critical workflows. There is also the issue of automation bias. As AI becomes more capable, there is a natural tendency to overtrust their outputs and reduce independent verification. Finally, the more we rely on AI-enabled tools, the greater the potential for large-scale failures. When something goes wrong, it may affect many patients or processes all at once. For these reasons, AI and QA demands an especially careful and thoughtful approach. If we look back at the history of QA, one thing becomes very clear. New tools inevitably change how people work. Artificial intelligence will be no different in this regard. It will reshape workflows, redistribute tasks, and alter how decisions are made. As a result, new workarounds will likely emerge. People will adapt to AI-enabled systems in ways that we can't anticipate. What this means is that oversight remains essential. QA cannot be fully delegated to technology. Instead, we need to actively monitor how AI is used in practice, how it influences human behavior, and how it changes the system over time. Ultimately, this is a reminder that quality assurance is a socio-technical activity. In a complex system, safety or lack of safety is an emergent system property that arises from the interaction between people, processes, and tools. All of this points towards the need to move beyond thinking of QA as a collection of tools or individual checks and towards a more system-based approach to quality assurance. In a systems-based model, QA becomes a form of system supervision. The focus shifts from evaluating individual components in isolation to understanding how people, processes, and technology interact over time. It's often those interactions, rather than a single failed component, that create the conditions for harm. By adopting this perspective, quality and safety can be more intentionally designed into our processes and equipment, rather than added as a series of after-the-fact checks. AI can play a role in this, but only as part of a broader systems-based approach to safety. One of the most important ways AI can add value is by enabling systems thinking. AI can help reveal interactions across complex systems. Interactions that are difficult for humans to see when data are fragmented or when processes span multiple steps and roles. This matters because as humans, we tend to oversimplify complex environments. That simplification is often necessary in order to understand the environment. but it can also hide important interactions that contribute to risk. AI offers the opportunity to examine systems without having to overly deconstruct them, which can then inform safeguards that evolve as the system itself evolves. In that sense, AI supports systems thinking by helping us understand the system more completely. I'll close by coming back to where we started. Quality assurance in radiotherapy has always evolved alongside technology. Each major advance has changed how work is done, how risk is managed, and how safety is achieved. Artificial intelligence is simply the next step in that evolution. Like every advance before it, AI is both a benefit and a danger. It has the potential to improve our ability to see risk, reduce variability, and support safer care. But it also introduces new hazards, new dependencies, and new ways that systems can fail. The path forward isn't to avoid AI, nor is it to trust it blindly. The future of quality assurance in radiotherapy lies in AI-enabled systems thinking, using AI to better understand interactions, inform adaptive safeguards, and intentionally design quality and safety into the systems we rely on every day. Thank you.
Perfect. Thank you. I must say that both Dr. Marks and Dr. Pawlicki been my mentors, especially Dr. Marks for 15 years, and Dr. Pawlicki, one of the most important person in our field to really think about QA. And I hope this sets the tone for the next phase and the final phase of this presentation. And I know you guys are very tired. This is end of the day, and I'll try to keep it light. But really, let's take a look and a little bit of a deep dive into an application of AI in peer review, while treating the AI as a partner for quality assurance, not a partner that's going to do work for us, but a partner that's going to come and we're going to try to understand how to really get that interactions in a correct way. So this research study is not about getting to the final point. It's about how we apply systems thinking, human factors, and try to understand how that partnership is being created. That's the work that I want to present to you. So how did we arrive on really thinking about what's the problem? Why do we need to work on it? We did some data review. We captured data from prostate cases between June 30, 2023 and November 8, in 2024 in our system. We reviewed 255 prostate cases that we looked at that went through peer review. Remember, those are the cases that go into the peer review. And we learned that out of the 255, 6% of these cases had some level of an issue with the contouring that was done by a physician, right? The physician works with the dosimetry team, but when it comes to peer review, the problem was identified. So 6%. Out of that 6%, 12 out of these 15 cases here had something wrong with the nodal volumes, right? And we're going to talk about it, but that's where we found that most of these issues arise in that specific contouring of the nodal volume. Going a little deeper, out of these 12 cases, 8 required changes, meaning that the peer review caught something that worried our providers, and they decided to actually make a change post-peer review before the treatment gets delivered to patients. Okay, so if you really think about it, and this is probably a low estimate, that about 3% of the cases, had some change. So the lesson one for us was, okay, we need, can we bring AI to help with this process? Can we bring a partner so that we can reduce some of the variability, so we don't necessarily bring cases with these major issues, right? But again, this is I'm going to come back to that point through my presentation. And okay, so let's take a look at the difference of a nodal volume and a target, right? So what we see on the screen here, we have a on the moving right now, the bladder, you can see it's very well defined. That contour is very well defined. If we look at the nodal volume, we can see that contour, it's much harder for physicians to perform. There's less of the guidance, there's less definition visually on the image itself, right? So that nodal volume contouring, makes it more difficult for physicians to accomplish, and there's more variability just because of that cases. So let's move on. So what are the challenges, right? We have in peer review, we have number of physicians that are present either in person or join in a virtual setting. They're going to vary. So we're going to have a different set of people and opinions during the peer review. Now, as we talked about, the nodal volume are even more difficult to analyze. And you have on the slide, I'm presenting a picture with the atlas, with the guidelines, specific guidelines that have been created by our colleagues. But what we are learning that not all of the physicians or clinics, necessarily follow these guidelines precisely, right? Through training, through other venues, physicians create kind of their own preferences of how they want to treat. So it increases the level of variability that the peer review needs to handle. And many cases are being reviewed, and the peer review needs to operate fairly quick. Cases don't have a lot of time because we got to move on. There's efficiency, right? In the clinic, this happens usually in the morning for about 15 minutes. So there's some time pressure on the team that is performing the peer review. So what did we do? We tried to develop a AI, and as you can see on the slide, we called it with the humor. We called him a jerk. We call him, jerk in the room, because we felt that this AI model, as we're going to bring him in and create this partnership, it's always going to have an opinion. So, it's like having a jerk in the room. He's always going to kind of show up and always going to say something, right? But that's good as long that the relationship between the AI, in this case, the jerk, and our team is going to benefit the QA and patient safety, right? So we decided to build that model based on the data that we have in our clinic. Okay, so to arrive, at the specific risks, and I'm going to go through the slides very quickly here. But as I mentioned before, as an engineer and as someone who really wants to ensure patient safety, we took our time to work with 5 radiation oncologists first, and we looked at 173 process steps of treatment planning, and including some of the most important failure modes that had been identified historically. And I know that we're looking at the step and the failure mode, not necessarily allowing folks think about it as an interacted system, but we still felt it was important to go step by step and identify the threats and really think about them carefully about what else could go wrong and how should we act when we bringing AI model into our system, okay? So we did that work, a lot of assessments. We also interview our radiation oncologists, asking them questions about what worries them when they wake up in the morning and they come to work and they think about this new system, what do they worry about? So we've done this. We have, our thematic analyses. We use our systems engineering initiative and patient SAPES model framework to help us categorize the thoughts. And we found some interesting results. And I do want to just point this on the slide that our own physicians felt that the suboptimal review of image segmentations by themselves was one of the highest risk that they see in the clinic. And that was really kind of eye-opening, to me and our team, because that the reflection kind of, further amplifies the importance of peer review and the importance of bringing AI to the system and doing this in a safe, right, in a trusted and a safe way. So that came up to be number 1 top risk, a threat, if I may, that has been seen by our physicians in a clinic. And I do want to just say, Why? Why is that the case? Because physicians recognize there is, when I visually inspect images, yes, I have variability because we all see the images slightly different when we contour in neural volumes. There are transitions that I have to understand as I contour and I go, through the patient layers. Those transitions are not easy to visualize and spot and apply the guidelines that tell us to, how to exactly contour in those regions. Technology is not perfect. The images coming from other centers and the way they be registered, they have issues. That kind of increases the variability. And finally, as I spoke, the policies and the procedures and the way we work in different organizations and how we were trained and how we communicate add another layer of those complexities that we need to deal with, right? So there is an explanation of why our physicians, do see this as a threat of their own contouring of these organs. So I'm going to have Dr. Brian Anderson explain a little bit more technically about the development and testing of our AI model.
Hello, everyone. I'm Brian Anderson. Thank you very much for having me here today remotely. And thank you also to Dr. Martz and Lukasz for providing more explanation about how our model has been beneficial or can be beneficial in clinic. I'm here today more to discuss about the development, testing, and the validation of our model, 𝐏𝐚𝐭𝐢𝐞𝐳. So from the 1,000-foot view, essentially this can be broken up into 3 key steps, which I'll cover briefly in detail here and then more in detail later. First step, retrieving and curating data. This will serve as our information for training, testing, and validation. 2 is going to be training that model, which involves investigating different architectures, evaluating each one's strengths and weaknesses, and learning from that to create our final model. And then step 3 is after we've created this model, we still need to create all of the necessary software to make it useful and integrated within our clinic. All right, so it's important to remember during this process that information for any model is rarely pristine, despite often being told that we have this lovely homogeneous data set or distribution of information. We often are dealing with historical data that's fragmentary, missing information, or mislabeled. Okay. So a lot of times when we pull information from these patients, the structure contains a number of other labels which are not clinically useful or were clinically used at the time of treatment. We kind of enjoy using the phrase garbage in, garbage out. And while it is vitally important to select the correct contours used in each treatment, review and refine each patient as we go, manual review of over 100 patients would be an extremely labor-intensive process. So in order to improve this, we broke down our data retrieval and curation process into a number of stages. First, identifying patients. Previous work by myself and others has created a specialized data architecture for rapid evaluation of any patient who was treated within our clinic. What would normally be about a 14-hour process to iterate through a single database has turned into less than a single minute. So what does this actually mean? This means that we can very quickly identify a patient cohort and curate based on expected volume, as you can see on our left here, verify that the images follow a similar expected distribution as others, as you can see here on the right. So we're essentially just reducing that overall time necessity, which allowed for us to create this model in a relatively reasonable time. So from this, we're able to identify 216 patients with 220 CTs. Several of these patients had multiple scans because they've come back for. That's why we have 4 image patients, which we then split into a 179 training and 41 validation set. And it's important to also note that a single patient does not cross these numbers. Right? Now that we have our data, we can begin creating the model itself. Fully convolutional neural networks is the broad umbrella of what we used, they've essentially been shown to be extremely successful in these tests in the past. We investigate the UNet-style architecture because of its voxel-wise segmentation ability. This looks like a U, that's why it's called the UNet. We augmented this structure with the attention mechanism shown in the top right. These models function essentially by inputting a 3D volume of the patient's CT and outputting a voxel-wise basis segmentation, a mask that says yes or no. So if we're creating these models, how do I actually evaluate if they're working in the way that I designed it? We evaluate them in two measures. One, the dice similarity coefficient. This is a measure of the overlap between two volumes. So if I have a volume here in blue and a volume here in red, the mathematical representation of the dice is 2 times their overlap divided by each one individually. Doesn't really matter to understand the mathematics behind it. What you really care about is that absolutely no overlap is 0 and perfect overlap is going to be a value of 1. So we want to be closer to 1. Next, we also evaluate how well our models are doing based on the categorical cross-entropy. This is a reflection of how confident the model is in its predictions and how correct those predictions are. It's highly confident and it's correct, it goes towards 0. If it's highly confident and it's wrong, it goes up. And so dice similarity coefficient 1 go to 1, lost, we want to go down. Okay. So while I might make it sound like the selection process is very straightforward, we UNet to the attention network or the attention net addition, there's a myriad number of parameters that can be tuned for the specific task. And a number of them is included below. So for model-specific parameters, we're looking at the number of convolution nodes to include, how deep the network goes, polling, max features, yes. And then, even after your architecture has been selected, you need to also tune how to train that model. So that can involve adding perturbations to the data itself, flipping the images left and right, adding noise so that each time an image goes through, it is slightly different, cropping, rotating, the learning rate, how quickly does the model learn or potentially overfit, and the batch size, how many examples are we getting? Okay. So this is a representation of what that process looks like. Here on the right, you can see loss. This is our categorical cross-entropy. We want this value to be lower, so lower is better. And this is just a couple of the features that we were looking at. So it's batch, evolutions, learning rate. All that really matters here is that we're starting to see a trend that the deeper our network is going, the more representational information it's getting, the lower our loss tends to be. So this is our exploratory phase where we're trying to identify what aspects of the model give us the best results. And you can see here that we spend a lot of time on 5 convolution layers because it seemed like 2 wasn't enough. 3 was getting a little bit better. 4 starting to turn down. 5, almost all of them are doing very well. Okay. So for our final model evaluations on our 41 patients that we held out, we had a dice similarity coefficient 0.79. So 1 is perfect, 0 is awful. To give some context into how good or bad this value is, there was an article published discussing consensus guidelines by a group of physicians for this exact same task. Essentially what they did is they gathered a group of physicians, asked for them to contour this lymph node region, and then they identified how well they overlap. So they did a dice score on how much all of them agree. And what they found was that the dice score for all of its physicians was 0.73. So ours was better in that comparison. Now, to be fair, we have the benefit that all of our physicians are at a single institution and that they can all agree upon consensus or at least push towards it. And this was a workshop that had been provided. After the workshop was completed, a consensus guideline dice went up to 0.18. So it did improve after they were all trained. But our model is very close in approximation to how much overlap and agreement there is with other physicians. Yeah, so how does this integrate exactly into the clinic? I'll go and play this video in a moment. It looks like I can't get it to play right now. But essentially, we have our model sitting on a computer outside of our treatment planning system. We have our treatment planning system for A station, and then we have a network location that all of them can see. The way it works is within the treatment planning system, we send over the CT slices to this watched folder, which then triggers our model to download or to evaluate on them and create a structure set, which then gets integrated back directly into the treatment planning system. Well, let's see exactly what happens. Start this over. So this is our treatment planning system on a patient. Come over here to the scripts and run the prostate node segmentation script. This is now sending the CT to a watched network location. Next, what's happening on the back end is the model is now reading these CT slices and then making a prediction of what the pelvic node region ought to be. So what we see here in pink is the previously defined clinical contour, CTP pelvis. And then what we see in blue, CTP pelvis AI, is our new prediction. Just looking at them from here, the overlap looks pretty close. Very good. All right. That's how it is integrated. So, yeah. Thank you all very much for your attention. I'm very sorry that I couldn't be there live to go over this with you. But again, thank you for having us, and I hope you all have a lovely day.
Okay. Thank you, Dr. Anderson here. And what I want to now, I hope that establishes enough level of understanding as we talk about peer review, we talk about, the system and systems thinking, and giving example and understanding of what the AI system looks like and how it functions. So we're going to talk about a study and some of the results of really trying to pay attention about how we're going to put this in a clinic, but we're going to first do this in a simulated environment, in an experimental design. So what we've done, we had 4 groups of our colleagues. So we had a simulated peer review, which we had 2 MDs, 1 dosimetrist who's driving kind of the system during the peer review, and 1 physicist. Of course, during peer review, you will have more people, but because this was just an experiment, and of course we had to put our people together, we worked with 16 participants, and we kind of formed these 4 groups. Each group, when they came to the experimental design, had to review 20 cases, that were given to them, right? So we say, hey, please think this is a regular case, regular peer review, work together and make the review. Each of these groups participated in 2 sessions. In session 1, there was no AI, right? So you kind of allowed us to kind of create a baseline understanding of what is happening in a clinic with only 1 contour present in front of them. And we study their discussion and how they make decisions. And in a session 2, 3 weeks later, people came in, and now the experimental design changed because each group now had access to see 2 contours, 1 human generated, and the other contour, as you saw on the screen, AI generated. And that changed the dynamic. And we study the recommendations and the discussion in both of these sessions. Okay? I do want to mention that in session 1, blinded, our groups were seeing 10 human generated, but they didn't know, and 10 of the cases were generated by AI. So we also had that additional layer in the experimental design where folks were blinded to what this 1 contour was present. All right? And each team was asked to provide recommendations using a major recommendation, moderate, or minor. and tell us what those are. And we asked dosimetrists to type it. So we didn't want to interpret their recommendations from a conversation. We asked them to actually type every recommendation, at the end of each of these reviews. And in session 2, we also ask another set of questions. One, which contour do you prefer? Now you see both. Which one do you prefer to move forward, the human one or the AI one? And ask also if AI was useful. All right? So let's take a look at the results from this experiment. First, I do want to say that to ensure that the groups felt psychologically safe as teams, we ran a validated psychological safety instrument. And very quickly, I don't want to go in depth here on this slide, but I want to tell you that, yes, the groups, via this measurement, it felt psychologically safe. So they felt comfortable with each other to speak up, to have kind of that important teamwork so that the peer review occurred. So we did check for psychological safety to ensure that there was no possible issues or some level of discomfort of, matching a specific physician with the dosimetrist. So that kind of allow us to at least have understanding that groups felt comfortable working together. We also measured, using a validated survey, the trust level at the end of the session 2. And I want to just quickly point that there was a relatively, low to maybe moderate level of trust in that new tool that the team saw. So we just wanted to capture their understanding and where they were kind of from their perceptions. As you can see, the scores here, it wasn't really high yet, as this is very new, in experience. And this is complicated slide, but I'm going to take my time to explain it. What you see on the slide is on the y-axis, you have the cases, right? You have the session 1, which is, you see the human-generated contours. So that's case 2 to 19. Those were the human-generated. And then you have cases 1 to 20 there at the bottom. And those were the AI generated. But let's remember, they were blinded. People did not know which contours in session 1 they were looking. But I wanted to divide this data for that visualization. Now, on each column, you see each group and session 1 versus session 2. And now the color coding is really the decision they made. So the darkest color is going to represent major decisions, major changes that they wanted to recommend during that peer review. And as we go to the moderate and minor is the shading of the color. So as you kind of take a quick look at kind of the distributions here, right, between sessions 1 and 2, there are differences, right? So the first reaction, kind of analyzing the data, is that bringing session 2 AI and looking at of how decisions or what type of decisions, there were differences, but there was no true pattern in this data set. And I do apologize that I don't have final results. This is an ongoing project, so I'm going to talk about a number of things, but I don't have definite final conclusions as I present to you today regarding this experiment. This is work in progress. But I do want to point to some numbers. If you look to the right, if you look at the ranges of recommendations from session 1 and 2, you can see that session 1 would range, the recommendations were from 4 to 10, 6 to 14, and in session 2, with jerk present, with the AI present, these ranges shrunk, 4 to 6, 4 to 7. So perhaps, as we're doing more analysis, this is potential indication that AI has potential to reduce some of the variability on how we view and how we give these recommendations. And that might be a good thing. We are not using the AI to replace what the humans do, but we're bringing AI to hopefully provide the guidelines and help people think, get us maybe to a more of a standardization long term, but at the same time ensuring that we still have intellectually stimulated discussion in a peer review. Otherwise, I do want to just point, as we sometimes think, why don't we give the AI, why don't the AI just do the work? The AI does a great job, and it could, and a lot of, for efficiency gains, it could be the result. But I want to challenge us as you look at these preliminary results and thinking that creating the partnership with AI in that room, allowing people to think and to work together and stimulate them together, each other's thinking, perhaps a greater benefit long-term from the educational perspective, but also from risk perspective, than just allowing AI to do the work. I know you spent probably a lot of time thinking about this in today, and you're going to probably think about it more. But I think this data somewhat is starting to help us understand it. And please note that we are doing a lot of additional work to understand more context behind these decisions. I want to also show this slide. It's a little bit simplified, but this slide allows you to look at the results where we only counted. If there were so the shaded boxes in this case on this slide just represent if you had 3 major recommendations. We just shaded it as you made major recommendations, you made minor, not the quantity of the recommendation, but just if you had each of the categories. So you can see these distributions here smaller as a result. But if you look at the data about was it useful, so on the right side of the graph at the end of each session, people ask, was AI useful? And you can see that 27 out of 40 was perceived useful. And 31 out of 44, see the cases, also was perceived useful. And it's a really interesting phenomena occurred that when AI was almost overlapping, very close with the human-generated contour, somehow during this experiment, our groups thought that AI was not useful, because it was almost identical. So it was not useful. And I think in this case, that type of a thinking just represents our initial experimentation. Because in fact, AI could be very useful when overlapped with human, maybe confirming in a sense that your human-generated contour and AI generate, which follows the guidelines and so on and so forth, are close to. That might be useful confirmation. But somehow, in this experiment, people would not view this as a useful thing. Last thing I want to talk about the results. You see in the columns, I pointed where you see AI, right? There's in case 2, for example, group 1, you see this indication of AI, but there's very few. This data represents when was AI actually preferred. And as you can see, not much. It was it was literally very, very little times that AI was preferred. So with lack of trust, as you've seen, there was still lack of trust in the technology. With kind of historical approaches, that we have, most of the time in this experiment, the groups decided to go with the human contour. They would give recommendations, but say we prefer human contour. And we, with these recommendations, very rarely the trust in AI to go with the AI was present. Again, this is the phenomenon that needs to be further analyzed and studied, because I think it's an evolution over time of how the AI models would be viewed, how they will create the partnership so that people can actually, trust that technology a little bit more. Okay. So those are some of our preliminary results that are tremendously interesting, and we are iterating through this. And I do want to just very quickly say that to further make our model better, we realize that a lot of decisions of nodal volume is in these transitions that physicians struggle. So what we have developed more recently, what you see on the slide, is a model, AI model, that allows us to segment blood vessels in the region. Nodal volume and the nodes spread mostly around blood vessels. So thinking that we can provide another visualization model that allows physicians see blood vessels as they see the contour of nodal volume can add potentially another layer of understanding and how we are creating guidelines. Because in fact, most of the guidelines that have been written by experts, as you can see on the bottom right, it's a small slide, are indicative about how much coverage, to do in the specific regions while you actually following these blood vessels. So again, we've been working very hard of getting the model to enhance our jerk to provide more context and more understanding of these anatomical structures for physicians. So we're doing some further development of that work. And again, just to kind of finish up, the goal is really to combine the models. And as I previously mentioned in the opening slides, but combination has to come at usability, creating something that visually can people enjoy and be able to perform at their best human abilities, ensuring that we can write workflows for peer review in a correct way, when to turn the AI model, at what point, when to turn it off, how we want to have a discussion when the AI model is running, what type of policies need to exist to ensure that we do this. So all those layers and interactions between human activities, usability, workflows, teamwork, policies need to be really thought through, and we need to learn about it using these simulated approaches before we can put something in the clinic. Personally, I would be uncomfortable, taking this AI model and running and putting in the clinic at this stage. The learning is essential so we actually can ensure, right, that no harm will be done. So a lot of exciting work moving forward. So thank you so much for your attention and the opportunity to give this talk. And a special thanks to Dr. Kartika Thapa for having me and really just working with us for many years now. And really inspiring a lot of this work as well. So thank you, and I'm happy to take any questions or have a discussion.
Thank you so much, Dr. Mazur. It was super interesting, and a couple of people were asking if we can have the slides. We'll get in touch with you on that. But we are pretty late on time, so I think we'll skip Q&A for now. And perhaps if people have questions, we can collate them and get your responses offline. Thank you so much, Dr. Mazur.
Of course.
Thank you so much.
Thank you.
Now I'd like to invite Mr. Aditya.
Yeah. Thank you. Good evening, everyone. I see the audience has dwindled quite a bit since this session started. But I'm hoping everybody here is interested to know what we've done. So just to continue with the theme of this particular session, essentially what I'll be talking about is looking at deploying an AI solution as a co-pilot, if you may, for doctors within primary healthcare settings in rural India. So I'm Aditya. I'm currently working as the Director for Monitoring, Learning and Evaluation at IntelliHealth. And this evaluation is basically a work in progress. This is the first phase for what we plan to be an assistant for doctors during teleconsultation. So before I move ahead, just a little bit of... okay. Oh, acha. So IntelliHealth primarily works to provide healthcare access to people who are living in rural and tribal healthcare settings through telemedicine. One of our programs that we've been running for a really long time is called Arogya Sampada, which is currently working in 30 villages in Nasik, in a very remote and tribal belt, where essentially to get to a hospital or any facility beyond like the primary healthcare facility is at least 20 to 30 kilometers away. Often people who require healthcare services or consultation with doctors are unable to get it in the time that they might actually require it. And looking at all of these issues, we started this project with 30 villages in Nasik. Primarily what the Arogya Sampada does is it utilizes a health worker to doctor model to provide healthcare access, which means that we have healthcare workers in the field who go visit patients door to door, collect any issues that they collect information on any health issues that they have or want to discuss with a doctor, and then they kind of connect them to a doctor after taking this entire history, and the doctor can then review the data that the patient has provided and then provide a teleconsultation, speak with the patient via video or audio depending on how the signal is. Over a period of time, what we realized is that within teleconsultations, doctors that work specifically for teleconsultations in rural areas often have to deal with a couple of problems. The first is that there is a lot of patients who require assistance on what is routine primary healthcare services. But the way that they articulate their problems is often incomplete or is not something that can be used in urban settings. They might not know, for example, what is the exact symptoms that they're undergoing. They may have very little knowledge of their past medical history, and the information is what I'd call noisy and very fragmented. So this is a problem that doctors deal with on day-to-day basis, and because of that, doing any kind of diagnosis or providing a comprehensive treatment plan can be extremely difficult. So one of the solutions with the advent of AI that we thought was to introduce an AI-powered diagnostic assistant, which essentially helps doctors reduce the amount of time that they would spend on documentation, on understanding what the patient's history is like. And what this AI essentially does is that it goes through the entire patient history and then tries to summarize it for the doctor, so that most of the effort that teleconsultation doctors spend towards documentation can actually be reduced, and their time can be more effectively used in doing what we would say is higher order thinking, which is to come up with the diagnosis and the treatment plan. Along with this, there are other issues. When a doctor does a teleconsultation, they are able to put in the diagnosis and the treatment plan, but there is no standardization in them, which makes it very difficult to review successive data or clinical events for the same patient, right? So they won't put the diagnosis that might be tied to an ICD code. They will probably just write the symptoms. The treatment plans may be incomplete because doctors can't decipher them until the patient has done multiple follow-up consultations. The reason that we wanted to do this rationale is, so we thought that we'll have an AI assistant, but it's very dangerous to kind of deploy a computer that thinks on its own and then suggest doctors on the field, right? So we did this evaluation as a simulated study to understand whether it's actually safe to provide an assistant like this in the primary healthcare setting. There is a lot of evidence in the global literature regarding this, but most of them are in specialist hospitals. They've been done where there is enough diagnostic equipment to provide very precise data on what the patient is going through, but there's very little evidence on its effectiveness in rural primary healthcare settings and LMIC. I think one of the studies we follow is based in China called the Brilliant Doctor Program. So before we go into the evaluation itself, I just kind of want to show you what the AI assistant actually looks like so that you understand what we've been working through. So after the assistant IU 2.0 goes through the entire history of the patient, it will generate a summary in terms of a differential diagnosis. It will provide you 5 most likely diagnoses that this patient might have. The doctor is able to read, of course, a summary, but if they want, they can kind of read more and understand why the AI is suggesting this particular diagnosis. They also have the ability to provide extra notes, and then the AI will kind of revise these suggestions depending on how they speak with the patient and what information they're able to gather. And then the doctor has the option of just selecting the diagnosis. So instead of having to type hypertension and running the risk of misspelling hypertension into 10 different things, they're able to select what has been standardized and aligned with an ICD or SNOMED CT code. And then decide what type of a diagnosis this is. So at the first stage itself, we are standardizing how the doctor is able to enter medical data for the patient. The second part is that after selecting a provisional or diagnosis or an under evaluation diagnosis, the assistant will also provide a treatment plan. It will suggest what are the medications that can be used for this particular diagnosis. And again, the doctor has the ability to not accept any of these options and enter their own. All of this again has been standardized. What we've seen in other teleconsultation applications is that often doctors don't follow the same format. Different doctors have different ways of putting in this data. Lastly, the AI will also suggest certain investigations that might be important for this particular case. And in addition to that, give a referral to the most ideal facility, as well as suggest when should the patient actually follow up with the doctor. So this was just to kind of give a gist of exactly how the AI assistant works. So the main objective of this study was to look at whether this AI assistant can be effective in improving the performance of doctors, and more importantly, can it improve the quality of the treatment plan and the diagnosis that we're providing in rural settings. So these are some of the main research questions. Primarily what we did was we did a matched case control study design, which is nothing but to create counterfactuals for the same doctors and then have doctors go through cases using AI and not using AI to figure out whether their diagnostic accuracy improves, whether the time taken is reduced, and whether the quality is improving overall or not. So I will not go into the study sampling size. We required at least 800 cases for this study. What we did was we actually inflated that sample and we did 1,000 cases, anticipating any issues because of bugs in the software, which might lead to data loss, or having enough of a sample to do some kind of subgroup analysis. Through this presentation, I'll mainly be focusing on some of the key learnings and overall outcomes. I won't go into the subgroup analysis. So how did we end up doing this? We had 1,000 cases. We selected 1,000 cases from what is a repository of over 10,000 cases. So our clinicians reviewed these cases, selected which are the top 1,000 cases which actually can be evaluated. Then these 1,000 cases were provided a ground truth. A ground truth is basically a benchmark diagnosis that can be used to evaluate the practicing clinicians' decisions once they actually go through these cases. So we had a golden data set of 1,000 cases. In step 2, what we did was we recruited 20 clinicians, independent of the clinicians who actually did this review, and we made them into 10 pairs. The reason for having these pairs is we match doctors based on various criteria, such as their experience, qualifications, where they've practiced before, what kind of facilities they've practiced before, so that they basically act as counterfactuals for each other. Basically, we wanted to see doctors that are at the similar level. What is the gain in their accuracy? Then we started randomizing cases. What that means is these 1,000 cases were divided into groups of 100. So there were 10 groups for 10 pairs. Within each pair, the cases were given to both the doctors, but we randomized who gets to use the LLM or the AI assistant and who does not get to use it. So every case was evaluated twice, once with LLM and once without LLM by a different doctor. But since these doctors are comparable, we take into account the fact that any kind of decision, like changes in accuracy, would primarily be because of the use of AI. And step 4, once all the doctors have provided their responses after using AI or not using AI, we evaluated with an independent set of clinicians who then mark them for diagnostic accuracy, time taken, quality of the treatment plan, diagnostic plan, etc. And lastly, that is basically the independent clinician's evaluation of all of the case result. These are some of the main parameters. You can go through them, but just to highlight, we're primarily looking at diagnostic accuracy. How often are they right and wrong about a diagnosis? What is their turnaround time? How much time does a doctor actually take to do a case with AI and without AI? Then we had different indexes to evaluate the quality of the differential diagnosis that the AI was suggesting. On both appropriateness and comprehensiveness. Appropriateness basically looks at fit of the diagnosis. Comprehensive looks at whether or not it covers all aspects that must be for a given diagnosis. We looked at the quality of treatment plan, where we looked at first completeness. Is everything within a treatment plan included when the doctor is giving the final prescription? But more importantly, we also used a medical appropriateness index. This is a standardized tool that is used to evaluate how appropriate medicines provided under any clinical treatment actually is. So higher medical appropriateness index score, a higher MAI scores, means that the treatment plan is of lower quality. Okay, so it's inversely proportional. Then we also had our clinicians review the quality of medical tests given, quality of medical advice, as well as the referral advice that was provided. So going to our key findings, what do we see with respect to the diagnostic accuracy? We see without the LLM and then compared to with LLM, we see around 12% increase, absolute increase in the diagnostic improvement, in the diagnostic accuracy of doctors when they started using an AI tool. You will see that this increase is basically from around 60% to 72%. Overall, this does seem low, and this is, one of the limitations of doing a simulated study is because these doctors couldn't speak with real patients. So, of course, the amount of contextual information they can gather, which helps them in any kind of decision making, is very low. So, given that, these are fairly high accuracies. If you look at some of the more recent publications, without AI, doctors using clinical vignettes would probably have an accuracy anywhere ranging from 30 to 50%. With AI, we see similar results. With regards to turnaround time, and this I think is what was most fascinating for us, we see that there's a 47% reduction in the time it takes for a doctor to diagnose. But please do note that this 47% reduction is also after everything has been standardized and has a good quality of data for review by clinicians later on. Without AI, doctors would be feeding in their own treatment plans, they'll be using their own individual languages. And initially, it was 4 minutes with very noisy data that doctors were able to feed in. And now we're looking at around 2 minutes, 10 seconds to do a case for a doctor with everything standardized and easy for even like a layperson to understand. Right. You'll see some outliers on this box plot, but that's primarily because different cases might require different times. There are some tech issues that might be leading to this. On evaluating the LLM provided answers itself, the suggestions itself, we see that actually 90% of the accurate diagnosis was within the top 3 of the differential provided, which shows a high accuracy for such AI agents in the first place. But more importantly, we only see 7% of cases where the ground truth diagnosis was not present in the options that has been provided by doctors. So even the scope of error is fairly low. And I mean, for a clinical setting, this is still high, and this is something that we're trying to push up as we refine our model. But in terms of appropriateness as well as comprehensiveness, you'll see close to 90% with respect to what the the AI is suggesting as a differential diagnosis. We also see that there's very limited or almost no diagnostic overlap in terms of these options being very different, so that they're not they might be clinically equivalent, but it's easy for a doctor to select between these instead of just actually having an option that might lead to some kind of an unsafe diagnosis. With respect to the treatment plan, so after the medication was provided, we had the doctors review exactly how appropriate the medication provided was. And we see that with the AI assistant, the MAI score actually reduces, it almost halves. Most of the gains that we see are from things like drug to drug interaction, dosage, as well as if the duration of the provided medication was appropriate or not. You see that this has almost halved between using an LLM and not using an LLM assistant. And like I said earlier, having a lower MAI score is better, which means that the medication and treatment plan is more appropriate as opposed to having a higher score. However, interestingly, what we did see was that the non-LLM arm performed a lot better when providing medical test, medical advice, and referral advice. We see that doctors who used an AI assistant were giving what could be considered as clinically accurate medical test advice or referral advice, but it was not feasible within local realities. And that's kind of where the challenge with using AI for generating treatment plan lies, which is essentially to provide information or enough contextual knowledge to the AI to be able to actually generate feasible treatment plans. And this is something that has also been evaluated in China. There's a brilliant doctor program, and Wang et al. Wang has done an evaluation, which kind of also sees that often the technical accuracy of what the AI suggests kind of there's a discordance between the technical accuracy as opposed to the cultural realities of those particular events and like the treatment plan, which basically means that AI may not account for what are the referral networks that are present in like a tribal village. It may not know the income class of like the patients that it is viewing, and all of those are contextual learnings that we have to provide to make sure that the responses coming are actually feasible for patients to follow, right? So in addition to the summative evaluation, we also did a bit of qualitative understanding of how the clinicians themselves perceive this AI tool to be, right? And what we see is that most clinicians described this AI as a supportive partner, as like a co-pilot, which enhanced their reasoning. But more importantly, it was a safeguard that doctors can often miss what might be very obvious suggestions or diagnosis. And whatever they are able to miss, the AI is able to kind of resurface them. So we hear examples from the doctors, things like it will remind us of the disease if we skip or we forget. So it will not let us make any human error, right? Or for that matter, one of the doctors said, I usually go with my thought process and then I cross check it if it's there in the diagnosis or the DDX list or not. And essentially, that's why we see this AI tool as not something that replaces doctors, but supports how doctors think, and to also act as like a scaffold to help them with better decision making and not miss out on any kind of a trivial issue that could have a consequence, right? Again, the doctors kind of echoed what we already found through our MA from our analysis on tests, referrals, and follow-ups, which is a reality gap in the context where doctors noted that the AI performed well in structured and straightforward cases, but it lacked some kind of contextual awareness, right? And these things are, of course, we saw that referral patterns were a little strange because the AI would be more conservative and tell a patient to go see a specialist or go to like a specialist tertiary level hospital. But within the Indian public health system, it is very easily managed at, say, the secondary level or even at like some of the primary healthcare facilities. Some of the other cases that they thought this didn't work with was it'll work good for like straightforward cases, but if there's some kind of complicated case, then it requires more care in reviewing what the the patient history has been. Sometimes some of the medications are not listed. We tried our best to make sure that the essential drug list was available for the AI to go through, but clearly there were medications that could be more accessible even if they're not on the EDL. Lastly, one of the challenges that they identified is barriers to widespread adoption, which we also anticipate, where they see that, of course, this can be easy for doctors to kind of provide teleconsultations in rural primary healthcare settings, and possibly replace some of the quacks or other alternative treatments that exist. But there is an understanding that doctors need to change their workflows, but more importantly, how can they practically include this in their existing workflow? So the type of training required is important. There is a high degree of sensitization which will be required for doctors, as we understand, in terms of not giving into automation biases, for them being able to integrate this kind of a tool and use it daily. So again, since this was a simulated environment, we think that the doctors were extremely encouraging. Looking at how this transpires on the field would be the next step and more important. So what are our key learnings? Successes, we do see an enhanced performance in terms of both increased diagnostic accuracy as well as an improved efficiency, reduction in consultation time. If there is a reduction in consultation time, we're hoping that this translates into doctors being able to spend more quality time with the patients, which is having like a deeper interaction with the patient, minding their bedside manners, etc., so that the overall quality of the consultation goes up. This doesn't mean that we'll just do a lot more consultations faster. Of course, looking at this as a cognitive co-pilot that can help validate the doctor's reasoning, give them questions to ask patients, and then possibly require fewer follow-ups to get the right diagnosis. But most importantly, we actually didn't have any unsafe or clinically inappropriate outputs which could put the patient's health or like life at risk, right? And that was a clear signal for us to go ahead with stage 2, which is to look at how this performs in a field setting. In terms of areas for refinement, we understand that there's a need to train the model more on locally relevant data. Most of what we've done is primarily based on how, say, in global north, doctors would give like some kind of a continuum or like patient pathway, but it needs to be more sensitive to realities in India, especially in rural and tribal areas, such as where Arogya Sampada is being implemented. The main deployment challenge that we see is that the model should provide feasible outputs rather than just ideal clinical standards. And lastly, to look at integration and training, which is to make sure that current clinical workflows are reimagined or doctors are retrained to use such a tool, and then providing adequate user training on applications that will be integrating these. But more importantly, like I said, on responsible use of AI, where should doctors give more weight to what they are thinking as opposed to what the AI is just suggesting. In terms of limitations, and these are just limitations of the study itself, what you need to understand is that we cannot generalize these findings because this is not a community or a population level study. And it's basically on retrospective case vignettes, which is like a very clean data, so to speak. The doctors can't interact with patients, so those are some real elements of an actual interaction that this study is missing. So those are some nuances that we need to take care of. Um, the control design and like the lack of real-time interaction uh, actually leads to that lower accuracy that you saw at the baseline level. Limited contextual familiarity, not of the AI model, but the participating clinicians, because we had clinicians recruited from various settings. So they were not necessarily aware of what happens in Arogya Sampada and in those 30 villages. Our doctors that practice with us more regularly are more aware, so they'll be able to come to diagnosis much faster compared to these clinicians. So you can say that these are like fresh clinicians who don't have a perspective on this particular reality, but that signals a broader point that as we take this from even Nasik to other states, it's important for these clinicians to also be aware of what are the public health trends in terms of what kind of morbidities exist, what are the patterns of different health issues with or seasonality of health issues, so that they can make more informed choices despite what the AI might be suggesting. And lastly, I've spoken about this quite a bit at this point, but AI models contextual gap itself. So the next step for us, and this is the last slide, one is for ourselves to deepen the analytical understanding of how quality and clinical depth of case information might actually affect how doctors choose and what the LLM also provides as suggestions. We would like to validate performance in field, but our understanding after doing this entire project is also that as we roll out AI solutions, it's important to run them in simulated environments first, so that some of the outright issues can be fixed before we just get on to testing this with humans, especially given how sensitive matters of health can actually be. And lastly, to develop integration and training strategy as we deploy AI or roll out AIs, it's important to parallelly and not post hoc think of these training strategies or training programs for doctors, and how doctors should be sensitized towards using AI in their day-to-day lives. Yeah, that's about it. Thank you for being so patient and sticking till the end. If there are any questions, I'm happy to take them.
I mean, although it's sort of, I mean, it looks retrospective, but I think you attempted to do it. It itself is a great thing, because often LLM, I mean, the model validates a lot of things what you tell about. I mean, for example, and that's a big problem, because so the patient comes to me and tell, look, I'm taking antipsychotic, I'm getting wet. Now, sometimes model will tell you, why don't you decrease antipsychotic? And the patient comes and sort of start arguing with you, and you know that the moment to stop antipsychotic. Now, only my question is the LLM that you created, no? The data was already existent. You have enough data or tokens to enter the system, or how do you did it actually? I mean, how machine learning happens?
So we didn't create an LLM. Actually, we used for this evaluation Llama model, I think Maverick 4. But what we did do is train it, and essentially the effort has gone into prompt tuning to make sure that how we are entering data is understood by the LLM in the fashion that we intended to. But I think initially we trained this model on around 250 cases or so, which were textbook cases, and then 10,000 cases from our own project. I mean, we filtered out of 10,000, I think eventually, I think we had 10,000 cases after all of them. So we trained it on that to understand how accurate the model is. So while our clinician team already did ground truth setting for these 1,000 cases, but that was for this evaluation. In addition to this, a lot of effort has gone into setting ground truth for all evaluable cases, and then checking where the LLM is going wrong, and then refining those outputs. These 1,000 cases were never introduced to the LLM until the time of evaluation, so that we could just make sure that the results aren't biased. But otherwise, yeah, you could say that around 10,000 cases or so have been used to train and then refine how this model actually works.
Explain it. Just when we check it, compare on the commercially available the GPT and all, but Llama, you look at it,
it's cost effective for me. That I need to take very about that day. Either around that probably then. Always but then sustainability come detail that who best perfectly for this.
So we did do that. We actually ran this for the model we ran. We compared between Llama, Gemini, two versions of Gemini. I think at that point we had Gemini 3, and on GPT as well, and DeepSeek. What we found was that Gemini at that point of time was the most accurate, giving us around 95% on top 5. On the top 5 DDX, and Llama was 92%. The reason we decided to go ahead with Llama is because of IntelliHealth's own commitment towards open source models and technology, and also 92 to 95%. It's enough for us to rationalize to deploy Llama. The next effort is essentially to move this top 1 accuracy from 70% to 95%, and I think currently we're around 91%, and hopefully in the next month or so we should have that accuracy as well. Okay, thank you everyone.